Welcome back, everyone, for the third and final presentation today as part of the 2021 virtual PKD Summit. Very happy to introduce this next gentleman, Dr. Louis Girard, who will be speaking on the navigating the changing landscapes of PKD. Dr. Girard joined the Division of Nephrology at the University of Calgary in July of 2010. He is a nephrologist and clinical associate professor who has developed clinics to look after patients with ADPKD, First Sclerosis complex, and inherited disorders of the complement cascade. His work in developing these clinics was recognized with the Dr. John Conley Innovation Award in 2018. Dr. Girard is a member of the Canadian ADPKD Recommendations Committee and the CAN-VASC-ANCA Vasculitis Guidelines Committee. He is heavily involved in randomized clinical trials. Dr. Girard has several peer-reviewed publications, which include being published in the New England Journal of Medicine. Dr. Girard has strong commitment to education and has won numerous awards for his teaching contributions at all levels of medical training. Without further ado, Dr. Girard, I'll throw it over to you.
Thanks so much, Jeff, for the introduction, and thanks to you and the PKD Foundation of Canada for inviting me to speak this morning. It's an honor and a pleasure. I'm just going to fire up my slides here. So I'm scheduled for 45 minutes here. I think we might even get done a touch early, and I'm, of course, happy to take questions after my talk. So today we'll spend a bit of time speaking about polycystic kidney disease, of course, but I want to frame it in the context of the program that we've developed in Calgary, and also looking back. And when I first did this talk in Alberta for our Alberta Kidney Day, it was 5 years after the introduction of tolvaptan, so that's why it was entitled 5 years. Now it's been 6 years, but I don't know if there's been any difference between the last year. It seems like all a blur with the pandemic. I wanted to explain a couple of the big words that Jeff had to say there, because it'll also give you an idea of where I'm coming from. So I'm a kidney doctor, but I spend a lot of my time treating patients with rare disease, and I also do a lot of immunology. So I do this procedure called plasmapheresis, where we treat acute and severe immunologic disease. And I'm also the director of our glomerulonephritis clinic, which is an inflammatory kidney disease clinic. And from that, I've actually built our PKD clinic, which we'll get into. The more I go on in medicine, the more I realize that no matter what condition someone has, their genetics play a large role in it. And so, I think there's a lot of links there. So that's a bit of framing for us today. Here is my disclosure slide. The one that would be pertinent to today is Otsuka in terms of receiving funding for doing educational events, and also one of their trials, which I'll get into through this talk. So I just wanted to make you aware of that. And so the main objective today is to go through and look at the advancement in care of patients with ADPKD over the past 5 to 6 years. But as I mentioned before, I also want to give you a glimpse into the program that we're developing in Calgary and how patients living with PKD fit into that umbrella. So whenever I think about any patient with complex disease, and this is particularly pertinent to patients with polycystic kidney disease, is you need to think about what the foundation of managing those patients will be. So one of the cornerstones of that foundation is standard of care therapy. We need to be able to offer the most up-to-date standard of care therapy. And unfortunately, in the PKD space, that's been lacking, although in the last decade and certainly in the last 5 to 6 years, we've seen a big evolution there. So once again, we're seeing research in this space, and we're seeing research that is improving outcomes in patients with polycystic kidney disease. The problem, though, becomes in implementation of standard of care lags behind research and when this data becomes available. And even if you think about very standard medications like blood pressure pills, like an ACE inhibitor or an ARB in patients with diabetes, those medications have been around for 20 to 30 years, and we still aren't perfect in terms of their adoption. So we need to spend a lot of time in terms of standard of care. Safety is also very important. And I think the teams that we build ensure safety. So I think, physicians in general are often thinking big picture management, but our skills aren't always the best in terms of safety. And so this is where teams come into play. And for example, in my glomerular nephritis and polycystic kidney disease clinic, I have a nurse practitioner, I have a pharmacist, I have a dietitian, and all of these people not only ensure that we're giving standard of care therapy, but also delivering it in a way that's safe and effective, in a way that I can't do on my own. So that's obviously very important. The next part of the foundations here is, sorry, I'm just putting my timer on because I just don't want to run over. The next part of the foundations is clinical and basic research. So how can we participate in research so that, we can have this movement between research that's successful and the emerging standard of care. So that's important. And the last one, which I have some slides on, is precision medicine, which is really delivering the right care to the right patient. And so even within PKD, we know all of the PKD patients are different. Patients may have different genetic components to their disease. They may have different other comorbidities. And so the question really becomes, how do we deliver care that's appropriate for you, the patient with PKD? So I'll speak a bit about that as well. So just in terms of some treatment and guidelines, I'm not sure if any of you are fans of Back to the Future, but this is the flux capacitor input module from Back to the Future. And believe it or not, there's a website nerdy enough where you can alter the date. So let's go from present date back to February 25th, 2015. And that's actually when Health Canada approved tolvaptan as the first agent to modify outcomes in patients with polycystic kidney disease. And what I want to highlight here, and we'll see the progression through time, is at that time, the only indication was to slow the progression of kidney enlargement. So there was no reflection here of protection of kidney function in particular. It was really just to slow growth. And we'll see how that's emerged over time. And actually, this is an email from one of my patients who actually, I think, ended up being the second patient in Canada on tolvaptan that wasn't in the context of a clinical trial. But she actually reached out to me soon after this and says, "Hi, I'm one of your patients with PKD, and I received a news bulletin from the PKD Foundation of Canada." And again, I think that highlights again why it's so important to have an organization like the PKD Foundation of Canada to advocate for patients with PKD, but also to keep their fingers on the pulse of what's going on. So she was aware basically instantly after it was approved and that it would likely come available in May 2015. And she was wondering if she may be a patient who would benefit from this medication. And it turned out in the end, that she was. But again, very forward-thinking young woman who pushed me to kind of get this process started in Calgary. And so here I don't want to bore you too much with data, so don't worry, we won't spend too much time here, but I think many of you may be familiar with this trial, which was conducted and published in 2012. And it randomized a large amount of patients with polycystic kidney disease to receive tolvaptan versus placebo. And in this graph, and I always bug the authors of the graph because I hate it, there's so much noise on it, but really the important part is the difference between the blue line and the red line here, which is listed numerically here. And this trial showed us that patients who were on tolvaptan, their kidneys did not grow as quickly. So that was very clear. And that's actually what led to that Health Canada indication change, or the original indication. But, the thing was, at the time, we didn't fully understand what kidney volume meant in terms of kidney outcomes. So many people thought that this trial didn't mean anything because they didn't know what kidney volume meant. And so that was a big hurdle that we needed to cross through the years. What was the secondary outcome in this trial showed us that actually The patients who were randomized to tolvaptan, again, had less progression of their kidney disease. And so that worked out to be about a milliliter per minute per year. And it's fair to roughly think about that as a percent per year protection. Because it's a secondary outcome, it's given less weight, but it was statistically significant. And so you will see how that influences our decision-making over time. And the other thing people said at this point, who were the naysayers, said, well, a percent per year, who cares? But as those of you know, who are treating patients with PKD, and also patients who, people who are, patients with PKD and people who are treating patients with PKD, this is a lifelong disease. And so a percent per year may actually be quite a significant outcome. And so we'll actually look into how that looks with modeling. So this actually led us to form a group because not only was this treatment novel and important, it actually to us showed that we could delay the progression of kidney disease in patients with polycystic kidney disease in certain groups of those patients, which we can talk about in more detail, but it was really the higher risk patients. But what this group also thought was, PKD is really a forgotten disease. Like, as nephrologists and as a medical community, we've probably done a disservice to PKD patients because we've really said, well, there's nothing we can do. So why don't we just leave you with your family doctor until you have pretty advanced kidney disease? And this group of which I was a part, we said, this makes no sense. We need to come back and look at PKD as a whole disease, not just as it pertains to to tolvaptan, and see what the differences are that we can make. And so we published this this guideline, or I shouldn't call it a guideline, but Canadian expert consensus recommendations in 2017. And one of the recommendations that we made, although it was buried near the end of the paper, was that we recommended that all patients with PKD be referred to nephrologists for assessment to determine what treatment should be initiated. And in particular, if they were candidates for tolvaptan, because that was the disease modifying therapy. But really, it was to bring those patients back, and I'll show you some protocols that we've developed since, and say, hey, you have PKD and you may not be a candidate for tolvaptan, but there's a bunch of other stuff that we should be doing. We should be getting your imaging done, whether it's of your kidneys or your brain. We should be looking at your blood pressure control. We should be looking to see, do you have other family members that could be affected, et cetera, et cetera. So I think, of all the stuff we put in this paper, that was probably one of the most important. And this actually led to a change of practice in Alberta Kidney Care South, where we mandated within our triage protocols for seeing patients that patients with PKD be seen within 3 months. So before, there was no delineation there, and sometimes those patients could be waiting 6 months, 1 year to be seen. And so we prioritized them to be seen within at least 3 months at the maximum. So after Tempo 3.4 was published in 2017, the Reprise trial was published, and the Reprise trial was actually mandated by the FDA. So the FDA said, if we want to use tolvaptan in the USA, we want another trial, and we want you to look at patients that have a bit more advanced kidney disease. And we also don't want the primary outcome to be kidney size. We want it to be GFR. And so it turns out in this trial of patients with more advanced kidney disease that we saw a similar 1.3 milliliter per minute per year protection. So even, slightly better than we saw in Tempo 3.4. And again, this was another large trial. So if you combine these things together, now we have 2 large randomized controlled trials that show us in different subsets of patients with PKD that there's benefit. Now, again, the important thing here is these trials did look for patients who were at high risk. So in order to get into Tempo 3.4, the original trial, the patients had to have large kidneys. And in order to get into the Reprise trial, the patients had to have low kidney function, which, we always say in medicine that the biggest marker of progression is actually having had progression. So again, I want to just highlight these are higher risk patients, and that tolvaptan may not be an appropriate therapy for all patients with PKD, but certainly some of them. So this actually led Health Canada to update its indication. And note the difference here. Not only do they mention slowing the progression of kidney enlargement, but now they recognize that this medication prevents the progression of kidney function decline as well. So that, again, in the last 5 years has been a huge step forward. And that trial also led to the FDA approving the medication in the United States. And this was actually one of the weird situations where Canada had access to this medication before the United States, and actually had developed quite an experience with it before there was ever experience in the United States. So that actually led the same group of authors to publish an update shortly after the last recommendations to highlight this change as well. And also at the time, there'd been a ton of data published in terms of recognizing that kidney enlargement rate or the kidney size at diagnosis is important and does correlate directly to kidney function, and also things around genetic testing, et cetera. So what we ended up doing in this paper is promoting that recommendation that I saw you earlier, which was near the end, and actually say, as our very first principle that all patients with PKD should be assessed by a nephrologist. And the reasons for doing that are to look at imaging, to look at genetics where appropriate, and also to look at therapies, particularly in rapid progressors. So, it might seem semantic, but, I think, again, this is, and probably obvious, but I think part of it's a reflection of what had happened to those patients living with PKD through the previous years. So just to give you an idea of global, and you'll see some of these slides have different backgrounds to them. I've been faculty on a bunch of different educational endeavors, so that's where these slides are coming from. But this one just gives you an idea of the global guideline consensus recommendations that came out. So that just to make the point that this isn't just a Canadian thing, but Japan, who are often leaders in many things, had guidelines on the treatment of polycystic kidney disease back in 1995, so way ahead of anyone else. And then they updated them in 2002 and then 2014. Afterwards, we see Australian guidelines come up in 2016. There are European guidelines that come up in 2016. And then the Canadian guidelines were published in 2017, although we did write the paper in 2016. It just took some time to get through the peer review process. And then the Americans come out in 2018 with their guidelines. Europe updates again in 2018, and then Canada updates in 2018. So this is certainly not just a Canadian phenomenon, but a global one in terms of how we treat patients with polycystic kidney disease. And so getting back to that question of, how do patients with polycystic kidney disease do when they're on the medication, and what does that 1% per year mean? So you can see here that if you're started fairly early in your disease course with, slightly low GFRs, but not super low, that on average, we can see a delay in the initiation of dialysis by 5 years. And again, you might say, well, 5 years isn't that much. It's actually a ton. So dialysis, as there may be people on the line who've experienced dialysis or know family members who've been on dialysis, is a terrible therapy for quality of life. So it's very hard on patients. And the survival on dialysis for all comers is actually lower than many forms of common cancer. Now, with that being said, patients with polycystic tend to do better on dialysis because it's really the genetic condition that's put them there rather than other things. But I think we can all agree that delaying dialysis is an important outcome. And that roughly translates into every 4 years for those patients who are appropriate for the medication of therapy results in 1 year of delay of dialysis. That's kind of what the modeling would suggest. Now, if you start later, it still does delay dialysis, but it doesn't delay it to the extent that if you start earlier. So that's enough about that sort of therapy. So the next part I'd like to speak about are kidney volumes, just so we can all be on the same page about that and what's the importance of measuring kidney volumes from a patient perspective and also a care provider perspective. And so, you know, as we showed you earlier, the TEMPO trial showed us that tolvaptan prevents progression of volume. And then the two trials together showed us that there's also a delay in progression of kidney disease. But the volume itself tells us how well you're going to do. So the volume of your kidneys at diagnosis is one of the important prognostic markers here. And so in the Mayo Clinic, they've actually developed this graph, which looks very complicated, but I'll just walk you through it. But basically, it was the first time, and again, this seems simple, but it was the first time that anyone validated the patient's age versus their size of kidney at diagnosis. And so to give you an example, a normal kidney volume in a male is about 400 milliliters total volume. Normal kidney volume in females is around 300 to 350. So you could see here, for example, if you're 70 years old and you have normal kidney volume, not surprisingly, you're going to do well. That's a class 1A. But let's actually look at a 70-year-old with a bit bigger kidneys. So let's say they have 800 mils, so double normal. They still, you know, don't do quite as well as patients who are 1A, but they're not in the worst risk category. But now let's take a 20-year-old with 800 milliliter kidneys, and they're all of a sudden in the worst category, which is 1E. So that relationship between the size of your kidneys at diagnosis and your age is very important. And it turns out if you plot that by these categories here, that the patients who have the biggest kidneys at the youngest age do the worst. Not surprising, but again, that is very important for us to know because it helps us to identify those patients we need to treat early and those that we may need to follow more closely. So all of my patients do get a Mayo Clinic classification done. And this website will also allow us to plot the patient in particular on this graph to give them an idea of where they are. And again, that can be frightening as well, but I think it also gives people the motivation to embark on treatment if they require it. So in Calgary, we actually were fortunate enough to be able to create a pathway with one of our radiologist groups to provide expedited MRIs to calculate total kidney volume. Now, I fully appreciate access to MRIs is a luxury. And so, you know, there are certainly communities in Canada where there is no access to an MRI or it's very delayed. Canada, as we all know, is a large geographic country that's quite varied. But you know, an ultrasound does help. So if we measure your kidney lengths with ultrasound, that does give us an idea of prognosis as well. So some other Calgary initiatives I'd like to highlight are the PKD Foundation of Canada. So during this time, there was a PKD Foundation of Canada chapter initiated in Calgary. And the chapter coordinator, Ardella Ridley here is a fantastic person. It's an honor and a pleasure to know her. And she's been such an important foundation of developing this chapter and organizing the group and also coordinating sort of events so that patients and care providers can get together and discuss. And I've had the pleasure of speaking at a couple of the forums there. So that was a big move forward for us to have a chapter in Calgary. And as I mentioned before, we also developed a PKD specific clinic as well in Calgary. So this PKD clinic was founded on the principles of providing excellent, complete, multidisciplinary and evidence-based care to patients with PKD. And also, as many of you know, particularly now in Alberta, it's probably at the worst of anywhere in the country. Healthcare resources are limited. So when we developed this clinic, it was really designed in a way so that we could leverage our existing human resources and infrastructure to achieve this goal. So as I mentioned before, I have fantastic partners in my glomerular nephritis clinic. And they also have helped me develop a tuberous sclerosis clinic, which is another genetic kidney disease. And from that expertise, we've used these same people to roll out the PKD clinic. So it's just to kind of use our expertise that we have and translate it over. This is where the PKD clinic is housed, and we started seeing our first patients in the clinic itself in May 2019. The Richmond Road Diagnostic Center is actually an area that we're looking to develop our precision medicine program in Calgary and Alberta. And so we're fortunate in this center. It actually used to be an old children's hospital, but it's been converted to an outpatient facility. We have labs there. We have access to advanced testing. We have geneticists there and multiple specialties that work there. So lung doctors, liver doctors, kidney doctors, any doctor you can think of has an outpatient practice here. And so the idea over time is to develop a one-stop shop and a hub where, if you had PKD, you could see your nephrologist, you could go see your geneticist if you needed to, you could see the liver doctor if you have liver involvement, you could go downstairs and get your genetic testing done, so that's kind of the idea of it. I'm not sure if any of you on the line are from Alberta, but you may be aware that since we did this in the pandemic, Richmond Road has become one of the central centers for testing for COVID. And so operations there have been diverted to support the pandemic. But our hope is once the pandemic has settled down that we can sort of resume normal operations here and get this moving forward further. This protocol, I don't really want you to read it in particular, but it's just that idea that we're trying to take the knowledge that we've worked on a national and the international colleagues have worked on and condense it down in a way where we can deliver consistent care to patients with polycystic kidney disease so that everyone goes through the same workup. And that certainly doesn't mean they all need the same therapy, but that we go through the same process every time to make sure those patients are treated to the best level of care that we can. So, part of it is establishing the diagnosis and using confirmatory imaging as required. And then identifying whether these patients require additional genetic testing or genetic testing in particular. And then the two big foundations are searching for complications. So making sure there are no aneurysms or brain complications, no heart complications, that their blood pressures are well treated, identifying other family members, looking at the risk of progression. So looking at their kidney function, looking at ultrasounds or MRIs, using scores, and then through the PKD clinic, reviewing by our allied health members for cardiovascular risk reduction, water, and again, we can discuss water, low sodium diets, and then determining whether these patients are low risk versus high risk, and instituting the appropriate therapies. So that's sort of the path that we use in our clinic. I'm not saying it's the only or the right one, but I think it's important that all patients with PKD or similar diseases have access to a consistent delivery of care so that we don't miss things. And why are genetics important? Well, I think you had a long talk, sorry, not a long talk, but a great talk this morning about genetics. So I'm not going to spend time on it in particular, but we certainly know that genetics in PKD will influence outcome, and there are mutations that may make you end up on dialysis in your 50s or need a kidney transplant in your 50s. I just had a patient who ended up on dialysis and he's 44. So genetic mutations are important in that regard. And the other thing, I'm a big advocate for genetic testing as well, because it may give us insight into the disease down the road. And also, as new therapies emerge, there may be therapies that come out that help one group of patients with certain genetic differences versus other patients with genetic differences. So a lot of this work is done by Matt Langtree, who's a Canadian as well. And Matt trained with York Pei, who's the guru of PKD in Canada. So we're very fortunate to have these types of high-level, internationally renowned researchers in Canada. So how did we further this in Calgary? So we actually developed a rapid genetic testing program. So one of the problems with genetic testing was that it would take we have in Alberta there are not that many medical geneticists, And so seeing them takes a long time. So often referrals are 18 to 24 months. And then after that, after the referral is completed, it may take another 6 months to get results back. So now we're talking about, almost 2.5 to 3 years. So we actually got together with our medical geneticists and said, hey, for the initial stuff, like, and this is not to put down the medical genetics role. Their role's very important, but in terms of ordering the test, oftentimes the nephrologists have enough knowledge to do that. And we actually came up with packages of how to educate the patient that were developed in combination with the medical geneticists. And then we were able to order those results rapidly on our own. And then depending on the result, determine whether that patient should then see a medical geneticist based on what the result showed or not. So this pathways ended up working very well. It's improved access to genetic testing and made it much more quick. And actually the medical geneticists are very happy with it as well, because it's taken some burden off of them as well. So we've actually published a paper in regards to this. Unfortunately, it's not in print yet, but I think it will be in the next couple of weeks. I was hoping it would be out today or by today. So, that's an important thing that we've been able to do. So I'm going to spend the next section of the talk speaking about precision medicine. So for this, I'd like you to take a step back from PKD for a second and just think about patients with kidney diseases or diseases in general. And I'm putting up this slide about cannabis, not in particular to make any comment about cannabis, but if you go to this website down here called straingenie.com, you can actually submit your saliva and they'll tell you what strain of cannabis is best for you. Now, if you come into a clinic with some medical problem and you give me your spit, I can't do anything with it in most circumstances in terms of telling you how I should treat you in particular. And so that's really like where I want to drive this is for the person sitting in front of me, what is the best therapy available? And you might say, well, this is pie in the sky, but the truth is in many patients who are afflicted with cancer, the cancer doctors now don't care that much what the cancer biopsy shows. They're actually more interested in what the genetics of the tumor show. And that is actually used to drive therapy. So I don't think it's that much of a request for us to start being able to do this in patients with kidney disease or PKD in particular. So I just wanted to make that comparison. So in our center, as Jeff mentioned, we look at after patients with a lot of rare diseases. So these are some of the diseases that we treat, and I don't want to spend a lot of time on here other than to say that all of these diseases are significant. Many of them have genetic bases to them that we didn't appreciate before. But I do want to use a couple examples to show you that things can happen. So Fabry's disease is actually a genetic disease that causes kidney disease as well, but it's a deficiency of a certain enzyme. And so we were involved in a clinical trial where we were actually able to take a patient's white blood cells, give the white blood cell the capacity to make this enzyme, and then re-engraft it into the patient. And surprise, surprise, all of the patients that went through that after 2 years still were making sufficient enzyme to prevent the disease. And for those of you who know about Fabry's, the actual treatment for Fabry's costs about $1 million a year. It's very expensive. So, it's amazing that we can take someone's cells, change them and give them back to them and alter the course of a disease. And that's really personalized medicine, right? You can't get more personalized than that. Gaucher's is a similar one. We're undergoing a clinical trial. Now, the problem, though, is that these are corrected by cells that we can access through the bloodstream and re-engraft through the bloodstream, and they're enzyme deficiencies. So solid organ disease like PKD is not as straightforward, but I'm hoping through time we can learn from these diseases about how to modify other diseases. And I wanted to show you another example of personalized medicine that we do in our plasmapheresis clinic as well, where we participate. Is say you have a cancer like a blood cancer like multiple myeloma or leukemia. What they can do now is take your T cells, which are cells that recognize foreign antigens. So T cells would also be very important, for example, in fighting COVID. But in this circumstance, the T cells, for whatever reason, don't recognize the cancer. And that's really why cancers emerge, is it's a failure of your immune system to recognize the cancer. The cancer has evaded the immune system. And so what we do with the T cell is we actually create a receptor on the T cell that can recognize the cancer itself. And then we implant the genetics for that receptor into the T cells, and they start expressing the receptor. We then grow a culture of millions of those T cells that are modified to recognize the cancer. And then we give it back to the patient, and those T cells go and attack the cancer. So again, this isn't yet first-line therapy for these types of cancers, but it is gaining a lot of traction in this space. And there's a lot of different cancers that this is being looked at for. So again, how amazing is this that, you know, we can take a patient's cells, change them, and try and treat a disease. So again, that's why I continue to want to be involved in precision medicine, and you know, can draw on these experiences from my other clinics to help kind of build these programs and move forward in terms of treating patients with other diseases. And so, as I've mentioned a few times before, the real idea, and I'm going to be really happy if we're better at this by the time I retire, is can we deliver the right treatment to the right patient? And even, you know, with tolvaptan, the way that we assess that is fairly rudimentary, I guess is probably the best word. Like, we're taking an MRI and looking at genetics and stuff, but, you know, wouldn't it be cool if I could take your blood sample and be like, you will respond to tolvaptan? Or I take your blood sample and be like, you will not respond to tolvaptan. And so before we put you on a medication that changes your lifestyle in a significant way, we could know that you wouldn't respond to it. So again, these are important things to think about down the road. So there are, to bring it back to PKD, there are therapies that are being looked at for PKD beyond what I've mentioned. So bardoxolone methyl, which you know, is a complicated medication, but has shown some promise in another condition, is a really, I guess, a souped up sort of anti-scarring medication. There's other derivatives similar to tolvaptan. There's medications that have actually been used in certain types of cancer that is now being transferred over and looked at. And there's also medications that already exist that are very cheap that are being looked at as well. So metformin and pioglitazone, for example, are diabetes medications, curcumin, cholesterol medications. So, you know, this area is active and there's a lot of ongoing research here. But again, I think the important thing to remember is that if any of these medications are successful, they'll likely only be successful in a subgroup of patients. And again, how do we figure out in a specific way who those patients are going to be? So I'm going to finish off the talk by just looking at the bigger picture in Canada, and then I'll be happy to take any questions from the audience. So in Canada, I mentioned earlier the clinical trial I was involved with Otsuka for. So this trial was mandated by Health Canada, and Health Canada said, well, if you're going to introduce tolvaptan into our population, we want you to follow patients as best you can to see if there's anything that comes out in terms of a safety signal, but also in terms of outcomes and things. And so this is called the C Major Registry. And even though, I mean, it's funded by Otsuka because nobody else would want to pay for such a thing in terms of following so many patients in a registry, it's given us a lot of information about patients who are treated with tolvaptan. So we can see in 2018, this was published at the American Society of Nephrology, the stages of kidney disease patients have when they're started on tolvaptan. So 1 being the least severe and 4 being the most severe on this chart, but as those of you know, 5 and end-stage kidney disease are more severe. So the bulk of patients are started fairly early, but we do have some patients that are started a little bit later. The most common manifestations in Canada at initiation are high blood pressure, liver cysts, kidney pain, blood in the urine, kidney stones. And some of the adverse events that are associated with the medication are predominantly having to pee a lot. And that's how this medication works, actually, is that we can talk about it in question period, but it basically makes you pee a lot as one of the side effects. And so we knew that from the clinical trials. And again, it's reassuring to see in our Canadian population that that's the most common side effect that we're seeing. The other thing that we learned through this program is the medication, patients who are started on the medication stay on it. So in the clinical trial, the dropout rate was 23%. Here, it's actually a little less than that, and that's amazing in a real world population. So this really reflects patients with PKD's dedication to being on a therapy that's available to them. So this retention rate is quite good. Most of the dropout, again, is because it is very tough on your life in terms of having to pee so much, and some people don't tolerate that well. The other thing that we learned is with the monitoring program that we have is that the liver events are actually lower than what was reported in the clinical trial. And the reason for that is because we monitor more frequently. In the original clinical trial, they only monitored every 3 months. Health Canada told us to monitor monthly. And because of that, we've actually seen very few liver events, and the ones that we have been either reversible. A very small chunk of patients actually had a liver event requiring that the medication never be reinitiated, but these patients all recovered. So there was no, for example, liver transplantation required. So again, good to see this in a Canadian space. Another endeavor that I'm co-chair on is CAN PKD. And CAN PKD is sort of a Canadian network of PKD care providers. And what we're trying to do is bridge the gap between clinical care and research. So kind of get everyone on the same page, delivering the same care to all the patients with PKD, but also be able to drive research because a lot of the times these studies are conducted in the big centers, you know, Toronto, Montreal, Calgary, Edmonton, Vancouver. And so through this network, there's a lot of patients that are treated in community hospitals or community practices or private practices. And so giving access to those patients to research, but also allowing us to move the field forward. So that's sort of the idea of CAN PKD, is really to bridge that gap between research and clinical practice. And then there's also Refer PKD, which is a part of UKidney. Jordan Weinstein is another nephrologist in Toronto who's created UKidney, which is an educational resource. And so Refer PKD is part of that. And so Refer PKD actually highlights the centers in the country that either see patients with PKD or, you know, are centers of excellence. And so this enables care providers to access these kidney doctors and their teams. So just some concluding statements is I feel that we're transitioning PKD from this forgotten condition into one that we are assessing and treating proactively. Of course, this is nowhere near perfect, but I think in the last 5 to 6 years, there's been a lot of advancement in this space. There have been huge steps forward made in terms of accessing radiology and genetics. Access to disease-modifying therapy has improved over time, but again, is not perfect. And so that continues to be an ongoing endeavor behind the scenes, is to try and improve access to this disease-modifying therapy in patients who qualify for it. And you know, the Canadian initiatives have evolved immensely. So hopefully I've shown you a lot of the things that we've been able to do in Calgary to help our patients with PKD, but also on a national level, there's been this national consensus recommendation group that's emerged. There's been CAN PKD, there's the UKidney initiatives, and then sort of underpinning all of this is the PKD Foundation of Canada, which I think remains the most effective tool for advocacy, linking patients and care providers together and trying to help and support research for those patients. So that's all of the questions, or sorry, the slides that I had for you today. I hope that it was informative, and I'm certainly willing to take any questions. I think there's a couple in the Q&A here. And Jeff, I think you're going to come back in here.
I'm back. That was excellent, Dr. Girard. Thank you so much for taking the time to go through. There's been so much progress made over the last few years in the world of PKD, and you've certainly highlighted the majority of it. There are a couple questions that I have on the side that came in pre-session, and then there's a couple in the box. So we'll start with the ones in the box for you, and we'll go from there if that sounds okay.
Yep.
I believe BC covers the cost of tolvaptan and is the only province to do so. Any insights as to whether Alberta will cover the cost of this medication?
Yeah, so that's a great question. So this is one of the battles I was alluding to before, and there still remains hesitancy on the part of the public payer to pick up tolvaptan, and it's been honestly a frustrating battle. We continue to battle in that regard, but currently I'm not aware of any movement forward there. All I can tell you is we continue to advocate for this because as many of you know, tolvaptan is a very expensive medication. There are programs that we can access to try and look at cost sharing, et cetera. But you know, I think the evidence in front of us, and Health Canada acknowledges it, is that in certain patients, this medication is disease altering and modifying. So we will continue to do this. I think BC was very forward thinking in terms of picking that up. Part of it also is how funding works. So in BC, their BC Renal Agency has its own funding. Similar to in Alberta, for example, our cancer group has its own funding. And so some of us have been advocating actually that, you know, could we get an Alberta or wherever province you're from, kidney group or agency to, you know, for us to prioritize what our spending priorities are. So I hope some of these endeavors will help down the road.
Thank you for that. And we, of course, as a patient-driven foundation, advocate for equal access as well, and have been banging our heads against the wall, much like the medical professionals in the field. So hopefully we'll see some changes. This is an overarching question, but we'll try and dive into it a little more specifically, if you may. It asks, is PKD a concern for patients who are already dialyzing? So you've spoken to the lack of quality of life that dialysis brings. We know it's a means of prolonging the quality of one's life, but it's not a treatment option. Can you speak to that in a little more detail?
Yeah, for sure. So that's a great question. So once you've ended up on dialysis, from a kidney perspective, you've suffered that sort of endpoint. And so by that point, the tolvaptan, for example, itself, if patients were on it, would be discontinued. But I think it's also important to acknowledge the other things that patients with PKD who are living with PKD go through on dialysis. So the one for me that remains, I shouldn't say the one, but one of the ones that remains important for me is the risk of aneurysm. So the risk of brain aneurysm in the general population is 0.9%. In patients with PKD, it's 9%. So it's 10 times higher in patients with PKD. Now, I don't want that to frighten patients with PKD because that still means that there's a 9 out of 10 chance you'll never have an aneurysm. But we do need to continue screening for brain aneurysms even when patients are on dialysis. And it's also a critical component of the transplant workup. So patients who are transplant eligible need an MRI of their brain to make sure they don't have a brain aneurysm either. In terms of other things on dialysis, patients with PKD can continue to have kidney events. So they can have kidney stones, they can have bleeding from their cysts, they can develop cyst infections. And then from a liver perspective, again, if the liver disease is a predominant one that can continue to progress despite being on dialysis. And this seems to be, unfortunately, more prevalent in female patients than male patients in terms of the liver disease. So those are issues that we may have to monitor and treat in an ongoing fashion. PKD patients generally, actually on a good side, the PKD cysts tend to make the hormone that make blood in excess. So frequently dialysis patients need hormone replacement, but in patients with PKD, we often don't need hormone replacement, which is a good thing. If patients are on peritoneal dialysis, patients with PKD are more at risk of having hernias. And so when you put the fluid in the abdomen with peritoneal dialysis, that may make the hernias worse and cause the fluid to leak. So again, that's another thing we may have to manage as well. So I think, I may not have touched on everything there, but I think even though patients with PKD end up on dialysis, that doesn't mean, or that doesn't indicate that their journey with the disease is over. And maybe the last one I would highlight, Jeff, is sometimes patients who are on dialysis with PKD actually need their kidneys removed due to pain or size. Sometimes we need to remove the kidney actually to make room for a transplant. So there's lots of stuff that still needs to be looked after on dialysis.
Speak to us a bit about maybe Calgary's opinion on the removal of the native kidneys then, because I know it's very institute by institute based decision making, but it's one of the bigger concerns in the PKD community is getting those monsters out due to the pain that they're causing every other part of their body. So where do you stand on that, and knowing that it's a patient by patient basis?
Yeah, I think that's a great question. So for in general, leading into end-stage kidney disease, if the patients are going to develop end-stage kidney disease, we're of course very conservative. We don't want to remove kidneys or even, poke them with needles and stuff if we don't have to. But once the patients are on PKD, it's been our opinion once the patients are on dialysis, it's been our opinion that if these kidneys are causing, pain, bleeding, or the patient needs room for a transplant, that we remove them. So we've had patients either have single nephrectomies or bilateral nephrectomies. The flip of the discussion is that removing kidneys is not an easy business. Patients who are undergoing any transplant, not just those who have PKD, often think that we're going to actually take the old kidney out and put the new one in. But that's not actually what happens. Is we actually generally leave the old kidneys in and put the new one in the pelvis. And the reason why it goes in the pelvis is because it's easier to access and it's actually not as bad of a surgery. So sick kidneys end up scarring, and taking them out can be very challenging in terms of bleeding. And then what sits on top of the kidneys are the adrenal glands. And so sometimes identifying the adrenal glands is difficult in patients with PKD because the anatomy is so distorted. So, in any of these decisions, we need to weigh the pluses and minuses. But in those, who have severe pain, who can't eat because the kidneys are so big, who are bleeding, who need room, we've certainly advocated to have one or both kidneys removed depending on the patient. And I had this person I was mentioning earlier who was 44 and ended up on dialysis. He ended up needing bilateral nephrectomies, and the total weight of both his kidneys was 44 pounds. So
wow.
Crazy. Yeah.
Yeah. Okay. Well, thank you for that insight. I want to take a moment and allow you to toot your horn with respect to your clinic in Calgary. Being the first PKD specialty clinic, I think is a tremendous accomplishment. I'm so thrilled to see more and more of them popping up as the years go on. And Refer PKD is, of course, that tool that you mentioned through UKidney. We have it linked on our site as well, so people can investigate and find where their closest PKD specialty clinic is. But just give us a run through on the value of having multidisciplinary care under one roof and why that's so important for PKD patient.
Yeah, so I think it's critical to have these centers for a number of reasons. I think, for me, one of the fundamental ones is that I would rather have, not that PKD is that rare of a disease, but I would rather have one person see 20 patients with PKD than have 20 people see one patient with PKD. So I think developing that institutional expertise, and that's not to suggest, for example, just I should see patients with PKD. Like I think, in all of these centers, I'm hoping over time they will identify a few physicians who have developed expertise in this regard. And then as important to that is developing the allied health professionals as well, who have this experience. And really the allied health allows the operationalization of the clinic. So, I currently have about 1,200 patients in Calgary, like not just with PKD, but just, in total. So I can't just by not being able to clone myself and not having the expertise in certain areas, deal with all of those patients. So having a pharmacist and a nurse practitioner that can really pay attention to the patients, look at the day-to-day labs, do education, make sure we're hitting our targets, enables me to kind of do things like open other clinics and take care of other patients on this level. So it's critical. The other allied health that we haven't discussed a lot are the dietitians, which again are very important for PKD and kidney disease in general. And also social workers, like there's a lot, and the pandemic's made it much worse in terms of finances and people having to decide between taking their medications and eating, so I think it's very important to have all these people with all their expertise come together and with the goal of delivering, I don't want to call it homogenized care, but just going through the same process with everyone and figuring out what the best care plan is for you, but ensuring that we haven't missed anything. So I think it's critical that these clinics continue to grow and develop.
Absolutely. And I mean, we've seen and heard from the community just how valuable the level of care is when they get into those clinics, from how they were being seen. And, the variance from 5-10 years ago when you would see your nephrologist maybe once a year and there was no treatment option, and they would, kind of hold off on any major decisions until the case worsened, versus one big takeaway from your presentation, I spoke to it earlier, is getting into that nephrologist and introducing them into your way of life as soon as possible has been a game changer for a lot of the community. It would break my heart hearing from people that were stage 4, stage 5 before they started to do anything about it. And how many times they were turned away until it got to the point where dialysis or transplantation is the only way. So I think by giving people that power so early on in their diagnosis, it's a win-win across the board.
Absolutely. And just, sorry, one more small comment there, Jeff, is also I think enabling getting to know the families. And I was actually just seeing a patient with PKD yesterday, and I'm seeing so many of her family members that I can't remember who they are. And that's actually a good thing. So we've been able to get so much of her family seen. So I think that's super important.
That's incredible. Very important. Next question. At what GFR can a person start tolvaptan?
Yeah, so that's a good question as well. So for this, it's I'm going to flip the question around a bit and put it to what's the minimum GFR that they can start at. So there's no top number. You can start with normal kidney function. The real requirement is that we have determined that you're at risk for rapid progression. And typically that's done with measuring the kidney volume. There are other ways to get there, and it certainly depends what the coverage options are. But for example, I always tell my patients that in general, you'll typically behave like your family has behaved. That's not, 100% rule, but it's sort of a guideline that we can follow. If we know in the family there's a severe mutation, so there's no top level GFR where I wouldn't start. And I think as the modeling data I showed you earlier suggests that the earlier you start in patients who are appropriate, the better. The bottom GFR is around 25. So the Reprise trial enrolled patients with GFRs of 25 to 65. So those were the patients with more advanced disease. And so based on clinical trial data, that's sort of the bottom GFR that we would typically start at. However, in these trials, they did leave people on the medication until like if and when they developed end-stage kidney disease. So typically we would stop tolvaptan around a GFR of 15, or if they end up on dialysis, it sort of depends on the care practitioner. So that's, for me, it's kind of the bottom line. Now the question is, would I start someone with a GFR of 24? Sure, like GFR, any blood test is actually built with inaccuracies. And as many of you know who are living with kidney disease, that the GFR will go up and down. And so we kind of need to draw a line through the middle and figure out where the baseline is. But, you know, I think in terms of what the trials have shown us, 25 is the number right now.
Great, thank you for that clarification. We have time for one last question, and it revolves around your opinion on water therapy. So,
yeah,
massive intakes of water to kind of contradict the action of tolvaptan.
Yeah, as I drink my own water. So yeah, that's right. So I think it's important for patients with PKD to drink water is the first message. So if you don't remember anything else, that's the first message. And we generally recommend 2 to 2.5 liters a day in patients who are not on tolvaptan. On tolvaptan, you're supposed to drink to your thirst. But in any PKD patient, even especially those who are not on tolvaptan, you should drink 2 to 2.5 liters a day. What does that do? You know, the main thing for us actually is to prevent kidney stone formation. It's clear that that's the case. So patients with PKD are at higher risk of kidney stone formation, and drinking 2 to 2.5 liters of water a day will help prevent that. The bigger question is, will drinking water slow progression of disease? The short answer to that is we don't know. But you can take the TEMPO trial or even the REPRISE trial as sort of a trial of tolvaptan plus water versus water. So in both arms of those trials, the placebo arm was encouraged to drink as much water as they could, and so was the treatment arm. Now, the patients who are on tolvaptan by necessity drink much more water than the patients who are not. But I think that's the biggest real world comparison we can do is when patients are in my clinic, I also tell them, you know, drink 2 to 2.5 liters of water a day. And when you look at the patients who were, and again, remember, this is the appropriate group. So these were high risk PKD patients. The high risk PKD patients who were on tolvaptan had less kidney progression than those who were encouraged to drink water alone. With tolvaptan, and actually when we look at it pharmacologically, we're able to suppress the hormone much more effectively with tolvaptan that we think is leading to cyst development compared with maximal water. Now, if you're a PKD patient and you're not on tolvaptan, drinking the amount of water that we saw in patients who are on tolvaptan is actually dangerous. So it can make your electrolytes wash out and cause what we call hyponatremia or low blood salt. And for most people, that number is around 3 liters. Everyone's different, so it's not a hard and fast rule. So what I would say is if you're not on tolvaptan, drink 2 to 2.5 liters of water a day. If you are on tolvaptan, you need to drink to your thirst so you don't get dehydrated.
Okay, thank you for that clarification. And Dr. Girard, thank you for making yourself available and your continued support of the PKD community. It's always a pleasure having you join us.
Thanks for inviting me again, Jeff, and to the PKD Foundation of Canada. It's always my pleasure to work with you guys and keep moving things forward. So it was a real honor to speak today. Thanks so much.
Excellent. We'll be in touch again soon.
Take care.
Well, everyone, that concludes our presentations for today and is our final presentation for this year's PKD Summit 2021. On behalf of myself and the board of directors, I would like to thank you all for joining us. I do ask that if you have the time, there is a survey link now in the chat. We'd love your feedback. That's how we make these events bigger and better each time. There are many ways to get involved still with the PKD Foundation, so don't lose us after this summit. We're right in the midst of our walk campaign, so we would love for you to get involved. Sign up today, register, fundraise for clinical research here in Canada. And we'll also be providing additional educational events through the fall and winter months in a virtual avenue as well. So be sure to sign up for our newsletters. As Dr. Girard mentioned, they are the best way to stay connected. And you can do so by visiting npkd.ca. There's a little box in the right-hand corner for you to put in your information. Again, thank you for your time today. I hope you found it as educational and informative as I did. And we look forward to being in touch again soon. Take care. Bye-bye.